안녕하세요. 서울
Hello, I am Dr. Ji Dae Kyong from Seoul May Orthodontic Clinic. Today is our long-awaited final session. I truly hope the previous lectures have been helpful for you. In this session, we'll take a look at a complex case. It's not highly complex, but among Class 1 crowding cases, this is one we can work through in a basic course. This is a Class 1 crowding case with a deep overbite. You may recognize this case. I showed it once during session 9 or session 10. What do you think? There is significant crowding, right? Both the maxillary and mandibular anterior teeth show severe crowding. You can also see a very deep overbite in the anterior region, and dehiscence can be seen as well. There's another notable feature. The maxillary anterior teeth look very narrow and elongated. Compared to what? Compared to the mandibular anterior teeth, they appear relatively narrow and elongated, don't they? This may suggest an anterior Bolton discrepancy, in other words, a tooth size discrepancy. Here are the cephalometric and panoramic radiographs. Based on this, we planned the clinical treatment. This can be calculated through model analysis, but it can also be obtained from the clear aligner treatment report. So, should we extract tooth number 31 or not? I don't often perform mandibular incisor extractions, but when the tooth size discrepancy is significant, lower incisor extraction can be considered. So we requested 2 treatment plans from Magic Align. First, a non-extraction treatment plan. Second, a treatment plan with extraction of tooth number 31. Now, if you take a look, in my opinion, this may not be sufficient and may require more steps, yet it resulted in a total of 35 steps. As you can see, a significant amount of molar distalization is required, and the amount of IPR is also quite substantial. It seems the treatment may take some time. So the question is whether molar distalization will work well in this case. Typically, the normal anterior Bolton ratio is around 77%. However, in this case, it is 86%, which is quite high. This may serve as a diagnostic basis for considering mandibular incisor extraction. With extraction of tooth number 31, this is the diagnostic setup. As you can see, molar rotation was partially corrected, posterior crowding was slightly relieved, and with a small amount of IPR, simple alignment and leveling were possible. This approach was not chosen simply because it looks easier. However, when the amount of IPR in the mandibular anterior region exceeds 1 mm, rather than around 0.2 to 0.3 mm, there are concerns such as hypersensitivity and other potential issues. Molar distalization is also challenging. So, we decided to extract tooth number 31. The treatment was carried out over 10 months using 23 aligners. You can see that the deep overbite was corrected relatively early. The results are quite good. We used a total of 23 aligners. Now, let's briefly review the 3 treatment strategies for deep overbite before moving on. As we discussed, there are 2 concepts. Absolute intrusion refers to intrusion of the mandibular anterior teeth. Relative intrusion can be achieved by posterior extrusion or by proclining the mandibular anterior teeth. So, what do we do when the deep overbite is severe? We apply over-engineering and request overcorrection. In fixed orthodontics, devices such as an anterior bite plate are used, whereas in clear aligner treatment, bite ramps are used to manage deep overbite. You can think of it in this way. It plays a role similar to an anterior bite plate in fixed orthodontics. It helps promote extrusion of the mandibular posterior teeth. If we compare this further with fixed orthodontics, it is similar to using a bite turbo. There are ready-made options available. Personally, I often fabricate them myself using blue resin. With additional consideration, Auxiliary arch wires such as a Ricketts intrusion arch wire can also be used for intrusion. From the patient's perspective, oral hygiene and self-care can be difficult. From the clinician's perspective, wiring is required, which is also challenging. In that sense, direct traction using screws can be an alternative option. So, in any case, when using aligners, as I mentioned in the previous session, if you take into account a few key factors such as bone housing, the treatment can work much better than expected. The treatment was completed over 16 months, using 37 aligners. As you can see, aside from the midline, which is acceptable given the 3-incisor setup, alignment and leveling, overjet, overbite, and interdigitation all show a stable occlusion. Let's compare the diagnosis with the post-treatment results. This was a Class 1 crowding case. Due to an anterior Bolton discrepancy, tooth number 31 was extracted. You can also see dehiscence here, and overall the dentition was not in an ideal condition. In addition, the maxillary anterior teeth appear narrow and elongated. The patient presented with a deep overbite. To address this, we applied over-engineering, leveled the occlusal plane, and extracted tooth number 31, resulting in good interdigitation. Aside from the midline, the occlusion appears quite stable. This is the occlusal view. So, what do you think? Do you feel comfortable handling a case like this? Now, the case I showed today highlights an important advantage of clear aligner treatment. Using the web viewer, we can request first and second treatment plans, use them to make informed decisions, and offer patients a wider range of treatment options. In addition, this case includes features commonly seen in Class 1 crowding, such as deep overbite, crowding-related rotations, and other associated aspects. I hope this case was helpful and informative. Did you find it interesting? I did my best over these 10 sessions, but there were naturally some limits to what could be covered in a 10-minute time frame. We've been running this one-day seminar for about 4 to 5 years now. Together with Dr. Lee Jong-kook and Dr. Lee Hack, we conduct a lecture that lasts about 7 hours. From the perspective of organizing key concepts and also as an introduction, it can be a very useful one-day seminar. Now, for those who want to go a bit further and build a deeper foundation, orthodontic diagnosis is, in fact, extremely important. This course places a stronger emphasis on diagnosis, including conventional orthodontic diagnosis. It consists of 10 sessions, totaling about 62 hours. I can confidently recommend this course to all of you. Haha, it feels a bit awkward saying that, myself. We've also prepared an advanced course for orthodontists, as well as for clinicians who already have some experience with clear aligner treatment and are looking to further develop their skills. Over 4 sessions, we'll spend a month working more intensively together, meeting on weekends to discuss and explore clear aligner treatment. I believe this will be a very valuable and rewarding time for all of you. I also hope you've been enjoying the lectures so far. Here, you can see a person standing on the shoulders of a giant, looking far into the distance. You've probably heard the phrase, standing upon the shoulders of giants. Clear aligner treatment is no longer unfamiliar, difficult, or inconvenient. I believe many orthodontists are already achieving great clinical outcomes. While I may not be a giant, if my small efforts can serve as even a small shoulder for you to stand on and support your clinical growth, whether in orthodontics or clear aligner treatment, I will continue to do my very best. Thank you very much for your continued attention and support. If an advanced course is planned next year, I look forward to seeing you again. Thank you.